What is the most critical and high-risk area in a hospital? The answer is ICU, Intensive Care Unit. This is where we treat patients such as ventilator patients, severe infections, multi-organ failure cases, post-surgery critical patients. In ICU settings, even a small mistake can directly affect patient survival. That is why NABH introduced the COP-9 standard, which ensures that patient care in ICU and HDU is structured, systematic and evidence-based. What you will learn in this video. In this video we will understand what NABH COP-9 standard says, what assesses check in ICU management, common mistakes hospitals make, and how hospitals can become COP-9 compliant. Let's begin. What is NABH COP-9 standard? The COP-9 standard states, the organization provides care in intensive care and high dependency units in a systematic manner. This means hospitals must ensure that ICU and HDU care is provided through standard protocols, structured systems, evidence-based clinical practices. This ensures high-quality care for critically ill patients. Objective elements of COP-9. COP-9 includes several key elements such as ICU care protocols, admission and discharge criteria, adequate staff and equipment, ICU bed shortage management, infection prevention practices, ICU quality assurance program, patient and family counseling. During NABH assessments, these elements are verified through ICU policies, patient records, staff interviews. ICU written guidance. ICU care must be provided according to written protocols and guidelines. These protocols are based on standard treatment guidelines, evidence-based critical care practices. This ensures consistent and standardized ICU treatment. ICU care bundles. Hospitals may implement ICU care bundles to improve patient outcomes. Examples include ventilator care bundle, sepsis bundle, central line bundle. These bundles help reduce complications and mortality in ICU patients. ICU admission criteria. Hospitals must clearly define ICU admission criteria. Admission decisions may be based on physiological parameters, diagnostic parameters. Examples include respiratory failure, hemodynamic instability, severe sepsis, requirement of mechanical ventilation. ICU discharge criteria. Hospitals must also define ICU discharge criteria. Once the patient becomes stable, they may be shifted to HDU, high dependency unit, ward. Hospitals should also define ICU transfer in criteria, ICU transfer out criteria. Staff must be trained on these criteria. Adequate ICU staff. ICU must have adequate trained staff, such as critical care doctors, ICU trained nurses, respiratory therapists. Proper staffing ensures continuous monitoring and rapid intervention. ICU equipment. ICU must have essential life-saving equipment, including ventilators, cardiac monitors, infusion pumps, defibrillators. These devices are essential for critical patient management. Statutory compliance. Hospitals must ensure that ICU staffing and equipment comply with applicable statutory requirements, national clinical guidelines. This ensures safe ICU operations. ICU nursing staffing. ICU nursing staffing must be based on patient acuity. A commonly referenced guideline is Indian Nursing Council recommendations. This ensures adequate nurse-to-patient ratios. ICU bed shortage policy. Hospitals must develop a policy for ICU bed shortages. This policy should include escalation processes, alternate arrangements. This helps manage critical patients during peak demand. Infection prevention in ICU. Infection prevention is a critical requirement of COP-9. ICU infection control measures include hand hygiene, isolation precautions, device-associated infection prevention. These measures help reduce hospital-acquired infections. ICU Quality Assurance Program. COP-9 includes an achievement element requiring hospitals to implement an ICU Quality Assurance Program. This program monitors ICU performance through key indicators. ICU Quality Indicators. Hospitals may monitor indicators such as ICU mortality rate, ICU infection rate, re-intubation rate, ICU readmission rate. Monitoring these indicators helps improve patient outcomes. Outcome monitoring. Hospitals should monitor risk-adjusted outcomes to evaluate ICU performance. Collected ICU data must be analyzed, used for improvement actions. This supports continuous quality improvement. Patient and family counseling. Family members of ICU patients should receive regular counseling. Counseling should occur at least once or whenever patient condition changes. Counseling content. During counseling, doctors should discuss current patient condition, treatment progress, expected outcomes. These discussions improve transparency and family communication. Documentation of counseling. Counseling sessions should be documented in medical records or recorded if necessary. Family acknowledgement is considered good practice. Common NABH non-conformities in COP-9. During NABH assessments, common observations include ICU admission criteria not defined, inadequate ICU staffing, weak infection control practices, ICU quality indicators not monitored, family counseling not documented. Hospitals should address these gaps to avoid assessment non-conformities. How hospitals can become COP-9 compliant. Hospitals can comply with COP-9 by developing ICU SOP, defining admission and discharge criteria, ensuring adequate ICU staffing, implementing infection control practices, monitoring ICU quality indicators. These steps help hospitals effectively comply with NABH COP-9 standards. In the next video of this NABH training series, we will discuss COP-10, organization provides safe obstetric care. If you want to learn NABH standards step by step, then like this video, subscribe to the channel, turn on the notification bell, so you never miss upcoming NABH training videos. This is Medi Quality Partners, your trusted NABH guide. Thank you for watching.